So we are coming to start with pharmacology, and I have to establish the fact that this is one of the easiest courses you can come by. Me saying it's easy doesn't mean. Can you mute your microphones, Mariama? Me saying it's easy doesn't mean that you don't have to learn. Saying it's easy means that when you put your mind to it, you realize that it's very easy to understand. And for this course too, it's easy to get an A and it's very easy to fail. So we'll begin. So these are the references that we'll give. Even if you don't get all, at least the first one, Rang and Dale, I'll be able to send it to Melissa to share to the class page. So introduction. So basically today it's so sad it's a short class. So I'll try and tackle things within your range and we'll complete as fast as possible. But as you are there, you should get your pens, your stuff ready to be writing because some of the things I'll say will not be in the slides. I'll share the slides at the end. Oh no, my boss said I shouldn't share the slides, so unfortunately you won't get the slides. So you should be writing as you go on. All right. So today what we are coming to talk about is mainly the catecholamines or the catecholamines. We are coming to talk about their synthesis to the end and their involvement in adrenergic pharmacology. You've done the parasympathetic. So this is the sympathetic pharmacology, also called the adrenergic pharmacology. Some agonists that we use in the hospital. I'm sure most of you are familiar with adrenaline. Cynthia, have you heard adrenaline before?
Yes, madam, I have.
Yes. So you are familiar with adrenaline, epinephrine, no epinephrine, but probably you don't know their differences. So we'll tackle that today. And then the different drugs that can mimic it. So the drugs that mimic the sympathetic nervous system are called the sympathomimetics or the adrenergic agonist. And then the drugs that will block it are the antagonists. You get it? Okay. So now what we are coming to talk about is about the nervous system. So let's take a look at the nervous system. As humans, our nervous system is divided into two: the central nervous system and the peripheral nervous system. When you talk about the central nervous system, it's what happens in the brain mostly. So the brain together with the spinal cord make up the central nervous system. And the peripheral nervous system is what happens at the peripheries. So any other part aside the brain and the spinal cord is the peripheral nervous system. And for that, you subdivide it into also two: sensory and motor. You get it? Sensory and motor. And when you come to the motor, also called the efferent, that's when you come down, you have the autonomic nerves, and you have the main ones being parasympathetic, sympathetic, and
Am I the only person experiencing them in the slides?
I've stopped sharing. Those who are joining. Okay, so now I'm not allowing anybody in again because the noise is too much. Please, are you following?
Madam.
Yes, please.
Yes,
Yes,
madam.
yes, madam.
Okay.
Yes, madam.
Yes, madam. Yes, madam.
Okay, I've heard. So inform your class, nobody should join again. If they want to join, they should go and sit by someone else. All right. Okay. So we are coming to specifically tackle the sympathetic nervous system, and that's what I said is also called the adrenergic system. So this one you can just try and know it, but it's a bit above you. So when you take the CNS, the SANS, that's the sympathetic nervous system. The SANS emanate from the thoracolumbar. So this one we are talking about the spine, the vertebra. So it emanates, what we are coming to talk about comes from the thoracolumbar region. I'm pretty sure Dr. Henne told you that the parasympathetic comes from the craniosacral, right? Did
Yes,
he?
please.
He did mention it. So for what Prof. Ameya, or what we are coming to talk about now, emanates from the thoracolumbar region. So that's the region it emanates from. And if you look at the neurons, the ending, the blue diagrams, you realize that this one acts on various organs such as the heart, the smooth muscles, your sweat glands, and all that. So for this slide, know that it emanates from where? The thoracolumbar region. Okay. So we come back to it. The main one, the autonomic nervous system. I said the main divisions are the parasympathetic and the sympathetic. The sympathetic is what mobilizes your body during extreme situations. So we often call it the fight or flight experience system. So when imagine I'm telling you, baby, Cynthia, turn on your video right now. She'll feel anxious. She'll feel like, hey, why me? Then a lot of thinking and all that. Should she leave the group? Should she still stay in the group? Go to a different room where the setting is fine? Is she now going to wear her wig? All those responses are what fight or flight. Or imagine we were in the class and the lion pops in right now. The boys will leave us first and the girls will try and get through the windows and stuff. So that's the fight or flight response. And that's what the sympathetic nervous system mobilizes. So some people will say it involves the E activity. So when you are exercising, you see those neurotransmitters are released. When you're excited, in an emergency situation, when you are embarrassed. So in the sympathetic nervous system, as I said, if I tell Beyonce right now to turn on the video, the heart will start palpitating, start beating. So heart rate will increase, breathing becomes rapid and deep. And all these are signs of what? Anxiousness. Then some people too will have their skin getting cold and sweaty and pupils what? Dilating. Some people, in certain instances, they will even tend to have diarrhea. That's when the two systems are all involved. And for the parasympathetic, where Dr. Henne has tackled, that one performs maintenance activity. So it's not necessarily an emergency or whatever. So digestion, defecation, diuresis, and mostly for that one, BP is low, heart rate is low. There's no cause of emergency for these things to what act up. So the parasympathetic is like maintenance. How you are all sitting right now, that I'm not calling you. If I'm to call William right now, his heart rate will increase and all that. So that will establish the fact that his sympathetic nervous system is what's acting. So this is the anatomy, general anatomy. So when you take the sympathetic, as I said, it emanates from the thoracolumbar region of the spinal cord. Then we have something we call the preganglionic and postganglionic fibers or nerves. As we go on, I'll discuss deeper. And then the location is close to the spinal cord. So know that it emanates from the thoracolumbar region. So what are the main neurotransmitters involved? Neurotransmitters are chemical signals that when they bind to nerves, they communicate to them that do this. So if I'm a neurotransmitter called noradrenaline or adrenaline, if I bind to the nerves on the heart, I will tell the heart to what? Increase the heart rate. If I bind to the nerves of the blood vessels, I'll tell the blood vessels to what? Increase the BP. So they are neurotransmitters. They communicate. They are communicating with signals. So acetylcholine is at the skeletal neuromuscular junction. And let me see if I have a diagram of it. So we have the preganglionic and postganglionic neuron. I'm coming. I need to get a diagram for you to understand. Uh, sorry. Are you with me?
Yes,
Yes,
please.
madam.
Yes, please.
Okay. Hannah, can you mute your microphone?
Okay.
Okay. So the neuron on top, the one on top, is what we call the preganglionic. You get it? It's preganglionic. Um, let me. Okay, don't worry. As we continue, but I would also like to meet you guys in person because some of these things I have to come in person to discuss. And I'm sure Melissa will get time for me. Yesterday I was ready and I was told 50 of you are leaving. So acetylcholine for sympathetic nervous system, parasympathetic, it is released at all autonomic ganglia. What I mean by saying this is that when you check the parasympathetic nervous system here and the sympathetic, you look at the preganglionic. Have you seen the preganglionic neuron? It's labeled that's the one closest to the pink thing, the CNS. Chrissy, can you see it?
Yes, please, I can see it.
Very good. So when you check the parasympathetic, you see that that one, the preganglionic neuron, is very long. And when you come down and you check the sympathetic, you see that it's very short. So that's one major difference between the sympathetic and the parasympathetic. The preganglionic neuron for the parasympathetic is long, whilst the preganglionic for the sympathetic, the one just beneath the parasympathetic, is short. And what are they releasing? So at the preganglionic neuron, they are all releasing what? Acetylcholine, right? At the preganglionic neuron, they are all releasing acetylcholine over here. Can you see? Hello?
Yes, please.
Yeah. When I ask a question,
Yes,
Melissa,
please.
please respond for me if I don't mention any name. So it's over here.
Yes.
And when you check the thoracolumbar region, you see that one too. This is the preganglionic neuron. This is the preganglionic neuron. And they are all releasing what? Can you see the red thing?
Yes,
Yes,
ma'am, please.
yes,
Madam.
madam.
Very good. They are all releasing acetylcholine. So what that's one major difference you can write in your notes. The parasympathetic nervous system has a long preganglionic neuron, but the sympathetic has a short preganglionic neuron. However, they both release what? Acetylcholine. And when they release it, they are releasing the acetylcholine to talk to the postganglionic neuron. So the pre is the one sending the information to the postganglionic neuron. So the postganglionic neuron, so for the parasympathetic, it will speak to it, and parasympathetic, the postganglionic will release acetylcholine. But however, when we come to the sympathetic, the postganglionic neuron, you see that it's even longer than the what? The parasympathetic one. So that's another difference. So when you come to the preganglionic neuron, for the parasympathetic, it's long, but for the sympathetic, the preganglionic neuron is short. And when you come to the postganglionic neuron, the parasympathetic is short, and for the sympathetic is long. And at the same time, the sympathetic, the postganglionic neuron releases norepinephrine, epinephrine, what have you. And this was going to act on your heart, your blood vessels, and the rest. So the major neurotransmitter involved here for the sympathetic is the norepinephrine. That's what's going to act on your effector cells or the various organs, the end organs. But for parasympathetic, the major neurotransmitter it releases at the postganglionic is still acetylcholine. Hope that's clear.
Madam, please take it again.
So I'm saying that the preganglionic neuron for parasympathetic is long, whilst the preganglionic for sympathetic is short. That's one difference. However, the preganglionic neuron, the neurotransmitter they both release is what? Acetylcholine. So at the preganglionic, notwithstanding where you are or where you come from, you are both releasing acetylcholine and it's going to act on the postganglionic neuron. And that's where another difference comes in. For the parasympathetic nervous system, the postganglionic neuron is short, but for the sympathetic, the postganglionic neuron is a long one. And at the end, the parasympathetic will still release acetylcholine to act on the various organs. But for the sympathetic, the major neurotransmitter it releases is what? The norepinephrine. So over here, you can have about 4 differences just by knowing what is happening here. Okay, very good. So I've spoken about this, we've talked about this. So acetylcholine, as I said, at all postganglionic neuron, it releases both what? It's released at all postganglionic neuron, whether sympathetic or, sorry, it is released at preganglionic neuron, whether sympathetic or parasympathetic. But at postganglionic neuron, we have only the parasympathetic releasing what? Norepinephrine. Acetylcholine. Sorry about that. Do you get it? So acetylcholine is released at preganglionic neuron for all, both sympathetic and parasympathetic. But the postganglionic neuron, it's only the parasympathetic that releases acetylcholine. We are not going to talk about that. What we are focusing on is the norepinephrine, and that is released at the postganglionic neuron of what? Sympathetic nervous system. So we are going to talk about norepinephrine. Some will call it adrenaline or the adrenergic. There's a slight difference, but it's still the same. Okay, so let's talk about it. So, how are these neurotransmitters released? We are talking about the neurotransmitters are stored in the neurons. So, how are they released to your various organs? So, there's a concept of what? Action potential. When action potential is like electricity passing through the neurons. You know, neurons are electrical, communicate by electrical means. So, when electricity passes through them, it causes something we call action potential. And with that, there's calcium moving into the cell. And when calcium moves into the cell, it will cause the release. Have you heard the concept of exocytosis?
Yes, please.
Have you heard the concept of exocytosis? Melissa?
Yes,
Yes,
please.
please.
Okay, very good. So when calcium enters a cell, during action potential, it triggers an exocytosis discharge. So all those neurotransmitters in the vesicles will be released. You see it shortly. So adrenergic pharmacology involves the study of agents that act on the pathways and is mediated by these major catecholamines, the norepinephrine, epinephrine, and dopamine. So when we talk about adrenergic pharmacology, these are the main neurotransmitters involved. Okay. So drugs are made to target their synthesis, their storage, their reuptake. And in the end, it means that if I'm attacking the synthesis of norepinephrine, it means I won't be producing more epinephrine. If I'm attacking the storage, I won't be producing more. That's the antagonist. So norepinephrine, one major thing it does is it acts on your blood vessels to cause an increase in BP. So hypertension, norepinephrine plays a role. So it means that if you want to treat someone with hypertension, it means you have to reduce what? The norepinephrine and epinephrine. Do you get it? In shock, when a patient, so hypertension is high blood pressure. When a patient is in shock, it means the pressures are what? Crashing, they are low. So that one, it means we need to produce more of the norepinephrine to what? Act on it. So in shock, we want to introduce more norepinephrine, more adrenaline, so that it will increase the BP. In asthma patients too, they have what we call bronchoconstriction. Their bronchioles are constricted, so they can't breathe in, and the air cannot be what? Absorbed into your alveoli. So what we target here is also the adrenergic. We produce more of the adrenergic. It will act on the lungs to cause what? Bronchodilation. Then in angina, that one as well, there's a blockade. So if anything, we have to open the vessels up. So we want vasodilation. All right. So catecholamines are synthesized by chemical modifications to the main amino acid tyrosine. So what I'm saying is that the precursor, the amino, we have about 20 different amino acids, right? Cynthia, give me one. Cynthia, can you hear me?
Yes, ma'am. Hello.
Yeah.
Madam.
Give me one example of an amino acid.
Okay, madam, we have we have
So, Cynthia, you can mute yourself. So there are about 20.
ma'am,
So
we have
mute.
leucine.
Okay. Okay.
Madam,
Can
we have
you
leucine.
uh,
We have glutamic acid.
can you mute yourself, please? Yeah, very good. Glutamate. All right. So I'll speak to Melissa tomorrow. Please, can you mute your microphones? I'll speak to Melissa tomorrow. I'll get 30 minutes with you guys, and your first assignment is to list all the 28 essential amino acids. So Hannah, can you mute your microphone? Okay. So this one, the amino acid involved is tyrosine. That's the precursor. So it starts with tyrosine, and then there will be synthesis, and then we'll get your adrenaline. So the process involved for the adrenergic transmission, first we synthesize it, we store it, we release it. It will bind to what the receptors, and after it is done with its work, it will be removed from the gap. Okay. So we have here, please, the person with the microphone on, kindly mute it. We have here our tyrosine, and that is what a lot of processes will be involved, and to be synthesized to norepinephrine. And this norepinephrine is stored in this purple thing. It's called a vesicle. Why is it stored in a vesicle? If it's not stored in a vesicle, some enzymes will break it down very quick. So you want to store it in a container, else these are all proteins. Tyrosine is an amino acid. So if you form a complex, it becomes a protein product. So if you don't store it in vesicles, proteinases will break it down. So it's stored in a container, a vesicle, just to keep it. And when there's what exocytosis, when there's a trigger, it is then what released over here. So when it's released, that's when it will come and act on these receptors to produce a response. You get it? When it's released, that's when it will come and act on these receptors to elicit a response. Okay. So what is the synthesis? So I mentioned it starts with the tyrosine over here. And then an enzyme called tyrosine hydroxylase will act on it. Then will form DOPA. Then another enzyme, DOPA decarboxylase, will act on it to remove the carboxyl group, the COOH. Then will form dopamine. But however, we want to form adrenaline. So what do? Dopamine B hydroxylase will come in, add an OH group. Then we have noradrenaline. Noradrenaline. Then when we add an extra methyl chain is CH3. So the only difference between noradrenaline and adrenaline is the presence of an extra methyl chain. So you can see it over here. This one doesn't have it, but this one has an extra methyl chain over here. So no, that's what no means one methyl group less. So it doesn't have the CH3. Do you get it? No, adrenaline does not have this, but adrenaline has it. And these all have one thing in common. The common thing is this group. It's called a catechol. So when you see two OH group and a ring like this, a benzene ring, it's called benzene ring. It means a catechol. That's why we call it what? Catechol amines. It means they have a catechol group and an amine group. Amine is the NH3. Okay. So it means that if you want to target synthesis, what do? We need things to block these pathways. So some drugs have come. We have alpha methyl which will block this pathway. If we block this pathway, it means it's not going to work again. Then we have another group that will target this side, the carbidopa. And if it targets it, it means we are blocking another pathway. It's not going to work. Do you get the concept? It needs to go through all this to get synthesized. So it means if we are acting on their pathways, we are blocking it, we won't be producing this end product. Okay. So this is it again. So tyrosine over here. Then the synthesis process that we discussed earlier will come in. And then dopamine. So we first have to store it in the vesicles. I said when it's not stored in the vesicle, what will happen, William? When it's not stored in the vesicle, what will happen? Or anyone can answer. When it's not stored in the vesicle, when we don't store it in a container, what will happen?
They will be broken.
Very good. They will be broken down. We have a lot of enzymes around that is ready to break it down. Who answered that question?
Madam, please me. Paulina.
Paulina. Very good, Paulina. Remind me when we meet in class. So they will be broken down. So we always store it in a vesicle. And when action potential comes about, and then what? Calcium. So we have calcium, and when it enters the cell, that's when exocytosis will occur. Then it will be released and it will bind to these adrenoceptors down here. You get it? Very good. So that's it. These are all target sites. So tyrosine, we have alpha methyl tyrosine. That what that can inhibit it. So if we inhibit it, it means there will be no synthesis of what? Noradrenaline. Then the enzyme that Paulina said that it will break the things down if we don't store it in a vesicle is what we call the MAO. It's called a monoamine oxidase. It's very quick. It's so ready to chew the noradrenaline. It's like a boy ready to chew some fresh gelby. So the monoamine oxidase is always ready to break down the noradrenaline. So if you want more noradrenaline, it means we need to target the enzyme that will break it down. So we have drugs that will inhibit the monoamine oxidase. Then we also have drugs that will inhibit the noradrenaline from entering the vesicle. It's called Restipin, but now we don't use it. But it's of importance when we want to induce depression in animals and the rest. Please, can the person mute the microphone? All right. Then all these agents are also involved. So let's talk about norepinephrine itself. So that's the principal neurotransmitter for the sympathetic. Bridget, can you mute yourself? The norepinephrine is the principal neurotransmitter for sympathetic postganglionic. We've established that. The principal one is the norepinephrine. Then we have dopamine. Dopamine is also essential in your excitation, the one that gives you euphoria and all that. So those who take these narcotics and all that, it increases their dopamine levels and they tend to become high. It's also involved, but we are not going to talk much about it today. And then epinephrine. Epinephrine is what? Just norepinephrine with one CH3 group. So that one too is essential and it's a major hormone of the adrenal medulla. Where is the adrenal medulla located? Just on top of your kidney. It's in the adrenal glands. Okay. So collectively, the norepinephrine, dopamine, and epinephrine, these three are called the catecholamines because they have a catechol group and an amine group. That's where their name comes from, catecholamines. So how do we stop their action? So if they are released, maybe action potential has occurred, calcium has entered, and there's exocytosis. When they are released, how do we stop their action? So we have something we call the norepinephrine reuptake inhibitor. So norepinephrine reuptake transporter. So the net. So it is released from where? One site. Let's say the presynaptic terminal, the pre. Don't confuse yourself with preganglionic and then the presynaptic terminal. It's different things. Preganglionic is when we are talking about the ganglions from the CNS, the thoracolumbar and all that. But the terminals are just the nerves involved, okay? So when we talk about the terminating the action of noradrenaline, we have the sympathetic terminal and the post. So the pre one will cause the release, and when it's released, then the action is done. The same the same presympathetic terminal is going to cause reuptake of it. And how? It has a transporter that can pick it up. It can suck it up from where it is released into itself again so that it will be stored in vesicles. So that transporter is norepinephrine transporter or NET or uptake 1. Okay, uptake 1. Another way we can terminate its action is also by what? Dilution. It will diffuse. Since we've released it, it can go through your whole body. And you know that when you spray something on yourself right now, the scent is strong on yourself that very morning when you spray it. If it's a botchy spray, when you spray it now within 30 seconds, the scent will go away. But after some time, you realize that you've walked around, so the spray, the intensity of the smell will reduce. Do you get it? So that's what we mean by diffusion or dilution by diffusion. So as they are in the system, they are in your blood, they will move around to other parts. Then their action will not be felt because they are very diluted. It's like when you want to make a sugar solution. If you use small water, you taste the sugar. But after some time, if you add plenty water, it will get to a time you won't even taste the sugar that much. That's dilution. Then the third way of terminating their action is metabolic transformation. This one we are talking about the enzymes that will break it down. Okay, so it is released. Now you don't want its action again. We have some enzymes called the monoamine oxidase. The monoamine oxidase. That's what I said is ready to what? When Paulina mentioned that they will be broken down, this is what breaks them down, the monoamine oxidase. And we have another one, catechol O methyl transferase, or the COMT. They particularly break down these catecholamines. So you would have it in your system to regulate the levels. If it's too much, it will break it down. So these are the three main pathways for what? Terminating the action. Either we cause it reuptake by the NET or the uptake 1, or it will dilute by normal diffusion. That's why I gave the spray example. Or the monoamine oxidase or catechol O methyl transferase, the COMT will break it down. Do you get it? So this is it over here. When we are done with its action, we have uptake 1 over here, which will take them back into the cell. So it will take the norepinephrine back into the cell. Or we have the monoamine. So this one told you about the inhibitors. Okay. So we have the MAO, which can break the norepinephrine down or the epinephrine down. It will break it down. Do you get it? Or some instances, the norepinephrine will just leave these places and cause what? Dilution. And when it causes dilution, their action will not be felt. Okay. So this one is too high for you, so we can skip it. We can skip this. And I want to also raise the something about the cheese reaction. Are you with me? Beyonce, are you here?
Yes, madam. Please, I'm here.
Okay, thank you. Mary, I saw Mary. Mary, are you here?
Yes, yes, please, I'm here, madam.
Hey, how many Marys do we have? Hey, then I'll mention Mary. All right. Thank you. So we have another concept called the tyramine or the cheese reaction. It's a very nice, interesting thing. And sometimes it comes to the hospital. So with the cheese reaction, no, I think this should be an assignment. just something short. When I come, I'll call one person at random, and me too, I'll do it. The cheese reaction. So tyramine is mostly found in cheese, chicken, liver, and beer. Beer ankasa is not the Smirnoff or whatever. The beer. Some people are taking monoamine oxidase inhibitors. It means drugs that will block the action of the enzyme that will break the noradrenaline down. At the same time, when you are taking that drug and you take anything containing tyramine, so either cheese, chicken, beer, or red wine, there's something that we call the cheese reaction that will occur. And in this one, there will be excessive release of what? Norepinephrine, noradrenaline. And your patients will present with a very severe headache. You think the patient is joking because maybe you think, oh, now when you don't have any condition, how can you present? The patient presents with a severe throbbing headache, tachycardia, because all these noradrenaline is released, so heart rate will increase, nausea, hypertension, arrhythmias, or stroke. Patients can die from this. It's a very severe condition. So go and read on it. Treatment, we use the alpha or beta blockers. We'll talk about it. Then I mentioned Recipen. Recipen, I said, is no longer used. This one will disrupt the transport of what? The noradrenaline into the vesicles. So back to what Belina said. If the noradrenaline is not transported into vesicles, it will be broken down easily. So you won't get anything. And what Recipen? Recipen is from one plant called Raufia. The plant appear. The plant appear. What it does is that it blocks the transporter that will help the noradrenaline to be transported into the vesicles. So let's say we have STC that will help you get into Accra. The Recipen will block it. And if let's say something is they are playing the FIFA World Cup in Accra, you want to go and watch it. We've all packed ourselves into the STC, and Recipen said, "I won't allow the STC to enter into Accra." It means we all cannot enter into Accra to watch the FIFA World Cup. So that's what Recipen does. It blocks what we call the VMAT. The VMAT. VMAT. The VMAT is our trotro that's going to transport us. So Recipen blocks it from entering the vesicle. So you realize that there are vesicles present, but however, they are empty because there's no adrenaline inside. So the stadium is there. However, the stadium is what's empty because we, the people that we are in the STC, trying to move into the stadium, we have been blocked. Do you get it?
Yes, madam.
Very
Yes,
good.
please.
Okay. So that's what Recipen does. And then amphetamine. People abuse this drug. So how do people become high when they take this amphetamine and the rest? So the amphetamine blocks the net. This is the net. What did I say the net will do? The net will take up excess noradrenaline into the vesicles so that they will be stored. So the net that is released here, the noradrenaline that is released in this synaptic cleft, the noradrenaline over here, this is the synaptic cleft. When it's released here, it now has to go and bind to these receptors here. When it's released and it's too much, the net is going to take it back into the cells, the presynaptic terminal. This is the presynaptic terminal. And what is receiving it is post. So the pre is what is going to discharge it. And then the post is what receiving the information. Do you get it? So this is the presynaptic terminal. So when the presynaptic terminal, there's calcium influx and it causes exocytosis, the noradrenaline is released. And when it's released and it's too much, the net will bring it back into the vesicles so that it will be transported into the what? Vesicles inside the presynaptic terminal. And the transport is done by the help of what? The VMAT over here. So amphetamine, what it does is that this plenty noradrenaline that is released, amphetamine will not cause it to be what? Released back, will not cause it to be sent back when it's plenty. It will block this net amphetamine will block the net. It will block it. So the noradrenaline will still be in your system. And that's what's going to cause, oh, I'm high, I'm euphoric. So those people, that's how it acts. Do you get it? So the amphetamine will cause the net not to work. So no adrenaline, dopamine, all the catecholamines will be present and the person will be high. It also prevents the monoamine oxidase. What will block it? The monoamine oxidase from working. It prevents it from working. So it means no adrenaline will be plenty and it will not be broken down. Do you get it? All right. So these are all pathways where it can act. All right. So summary with the storage. We say it enhance or mimic what? No adrenaline. Drugs that will enhance or mimic their transmission. We have no adrenaline. Cocaine also blocks the net. What is going to cause the reuptake? That's what cocaine blocks. So obi offer cocaine, the person is high because what is going to send the norepinephrine back into the terminal has been blocked. And you have to understand that if the norepinephrine is not released here like this, it's not going to act. So if it's just stored in the vesicles, it's just stored. It cannot act on anything. So unless it's released, it's not going to act. So cocaine, when it releases this, it doesn't allow it to go back inside again. So it will be in your system, sir. You'll be high, sir. You get it? Okay. So now that we've understood the concept of noradrenergic synthesis and transmission, let's look at the receptors. Have you done anything on receptors? Melissa, are you here?
Yes, please. Yes, please.
Who taught you?
Please, Farm Obese.
Okay, Dr. Obisi. That's fine. Sorry, Prof. Obisi. So when we talk about adrenergic receptors, we have two main receptors, and this is the part I love most because when I teach it, the students understand it very simple. So I'm expecting that you nursing students would also understand it very simple because this concept is very, very nice. Over here, we have two main receptor families. I hope you are writing as I'm talking. So the main receptors are the alpha adrenoceptors, alpha and omega, that's spelling alpha, and then the beta. Is it not simple? You just have to learn these two, alpha adrenoceptors and then the beta. So the alpha, where do they act? On the smooth muscles. And this smooth muscle, the main site is the blood vessels. So alpha works on the smooth muscles of the blood vessels and they have excitatory effects. If we say they have excitatory effects, it means they can cause what? Calcium influx. And whenever calcium enters something, there's going to be an effect, an exaggerated, or there's going to be an effect. So they have excitatory effects, meaning that they can cause constriction or contraction. So if it's the blood vessels, they can cause vasoconstriction. Write this down. So when these noradrenaline, the catecholamines, the adrenaline, epinephrine, when they bind to the alpha receptors, specifically the blood vessels, they cause vasoconstriction. Vaso means vessel. Constriction means it's decreasing its size. So the vessels will what? Become small. The vessels will decrease in size. And whenever vessels decrease in size, the pressure increases. So causing vasoconstriction will cause an increase in blood pressure. Causing vasoconstriction will cause an increase in blood pressure. And when you talk about so the adrenoceptors, the catecholamines, when we get to this side, we remove dopamine, and we mainly talk about noradrenaline, adrenaline, and the third one is isoprenaline. Noradrenaline, that's the NA, adrenaline, and isoprenaline. Do you get it? So noradrenaline, that one has high affinity. It's like when someone asks you, what's your type? And I say, oh, me, my type is fair boys or dark boys or whatever. Do you get it? So noradrenaline has high affinity for the alpha receptors. It means that one, that's the type. No matter his attitude or whatever, so far as or yeah fair boy or so far as his alpha adrenoceptor, I'll prefer that. Followed by adrenaline. Adrenaline doesn't really mind if it's fair or tuntum. So adrenaline will be like, yeah, anything I like. So it's in the middle. And isoprenaline. Isoprenaline does not really like fair boys or maybe dark boys. Do you get it? It does not really like the alpha receptors. Sorry. So that is it. So no adrenaline. When we are talking about alpha adrenoceptors, the one mainly found on the blood vessels, no adrenaline. That's the type, followed by adrenaline, followed by isoprenaline. Then the next type is the beta. The next adrenoceptor is beta adrenoceptor. That one, when you bind to it, it relaxes smooth muscles. So you get it. Alpha will what? Contract or constrict smooth muscle. Beta will relax smooth muscles. Who is that? So beta will relax smooth muscles. And beta also has another effect. So for smooth muscles, it relaxes it. But on the heart, beta receptors on the heart will excite it. It will increase the heart rate. It will increase the pumping. So do you get it? Beta receptors, when they are stimulated, it causes relaxation on smooth muscles. But on the cardiac muscles or the heart muscle, it causes excitation or contraction. And when you come to the beta receptors, that's when isoprenaline will say, me, I now have my type, and my type is dark boys, dark tuntum brony, dark boys. So isoprenaline prefers beta receptors, and adrenaline still is, I don't mind, so far as oye nipa ne de mepe. So adrenaline doesn't really, it's in the middle. Do you get it? And no adrenaline will say, nah, me, I don't really like the dark boys, but obey if I don't have an option, chill. But isoprenaline will say, this is what I want. So when you come to beta receptors, isoprenaline is there. So therefore, we can conclude that adrenaline is what? Mixed alpha beta agonist. Isoprenaline is virtually a pure beta agonist with just a few alpha effect because it doesn't really like it. Then noradrenaline is also a pure alpha agonist with a few what beta effects. Okay. So the subdivisions. So
Madam,
yeah.
please, I have a question.
Yeah, what's the question?
Madam, please, when you were talking about the beta, um, you were saying that the cardiac muscle construct and there is muscle constriction, and
No. Stop.
I wanted to ask why, because
Yes.
you initially said that it causes relaxation, and you said except the heart muscle, the cardiac muscle.
Yeah, so we'll come to the why. But what I
Okay.
want to establish is we have smooth muscles. The smooth muscles that we are talking about here is mostly the blood vessels for the beta, the blood vessels and your
Okay.
uterine muscles. So this one is mostly for the women. We have cramps. So you see that even in childbirth, these drugs will be implicated. And I'm saying that the beta effect, it has stimulatory effect on the cardiac muscle.
Okay.
Okay, so that one is not included in this smooth muscle that I'm talking. So
Oh,
the cardiac muscles or the cardiac smooth muscles are not part. So beta receptors. So when we come in deeper, you see that we have different beta receptor subtypes and
okay.
they have different effects. Okay, so now let's look at the alpha receptors that we said have excitatory effect on the smooth muscles. So the alpha receptors, So the sympathetic, we have two main receptors, alpha and beta. When you take alpha, that one to underrate, you have two main receptors. So it's like that joke that they said, in everything there are two things involved. When you take this, there's two things involved. When you take this two, there's two. So that's it. So we have alpha, beta. When you take alpha, there are two things involved. We have alpha 1 and alpha 2. Alpha 1 and alpha 2. Alpha 1 receptors are located postsynaptically. So those on the postsynaptic terminal, those are what is going to receive the noradrenaline. You remember that I mentioned that something is released from somewhere and someone is going to what receive it. So this is like the concept of what yeah, I can say this, you are all adults. It's like the concept of intercourse, the man and the woman. The man is what? The prey, and the woman is the post. Do you get it? I'm saying this to make you understand it. The man is the presynaptic, the woman is the post. So we are saying that the alpha one is found on the post, meaning that they are going to receive it. They are the what? Effector cells. So they are located on the post. And when you have alpha 1 receptors on the post, let me draw this. So this is the prey, and then this is the post. You get it? So we have no adrenaline in this, or adrenaline in the prey. This is prey, and this is the man, and this is post. Okay. So we have alpha 1 receptors on the post. That's when adrenaline is released. It will bind to it. Okay. So this is adrenaline that is released from the post. It will bind to the alpha 1 receptors on the post. Do we get it? Is it clear?
Yes, madam.
Okay.
Oh, madam.
No, madam.
No, madam.
No, madam. Okay.
Oh,
Let
madam.
me get it. So we have the postsynaptic and then the presynaptic. We are saying that alpha 1 is located on the postsynaptic, and that's what I brought in this concept. So the presynaptic is what is going to cause what? The release of the noradrenaline in the vesicles. You remember that noradrenaline is stored in the what? Vesicles, right? So noradrenaline or norepinephrine is in the vesicle. Then we have the postsynaptic vesicles. These ones are going to receive the noradrenaline when it's released. Oh, sorry. These ones are going to receive the noradrenaline when it's released. So we have noradrenaline being released. NE, let's say these are the noradrenaline, the small dots. So the prey is the one going to what? Release the noradrenaline from here into this space. This space here is called the synaptic cleft. Synaptic cleft. So it will release the noradrenaline here. So you see small noradrenaline, small noradrenaline. Then we have this thing coming in. This is the post. This is the woman. This was going to receive the noradrenaline. And I'm saying that on the postsynaptic, that's where you have these receptors, alpha 1. So they are mostly found on your blood vessels or your effector cells. The alpha 1 receptors are found on your blood vessels, meaning that you have your blood vessel here. Let me quickly insert something in. You have your blood vessel here. Let's talk about it. I want an You have your blood vessel here. And on it, these things are small things. We have the postsynaptic. Okay. And on the postsynaptic, we have this. This is alpha 1 receptor. This is alpha 1. So the presynaptic terminal, which is here, storing the norepinephrine, will cause the release of these things. Okay? Will cause the release of norepinephrine or adrenaline. And it's going to bind to the alpha 1 receptors on these blood vessels. It will bind to the alpha 1 receptors on the blood vessels. And when it binds to them, that's when their excitatory effect will be felt. So if the vessels are like this, when it binds, the vessels will become small. Get it? And when the vessels reduce, this is the lumen of the vessel. When the lumen reduces to become this small, BP will what? Increase. BP increases. Is it clear?
Yes.
Yes, madam.
Okay. The guy that said he didn't understand, is it fine now? Hello?
Yes, madam.
Very good. You can ask me any question. So tomorrow, that 30 minutes, you can ask me. We have just an hour to. It's a 2-hour class, right? So we have just an hour to finish this one. So the alpha 1, that's where they are located postsynaptically. So they are going to receive the signal and cause the effect. Then alpha 2 are located on the presynaptic terminal. So the alpha 2, so this is the pre, this is the post, right? You remember? So alpha 2, they are rather located here. Alpha 2. And the funny thing is that when you release this, the norepinephrine, and it's plenty, one will go and bind to the alpha 2. And when it binds to the alpha 2, it tells the presynaptic, it tells this thing that stop releasing, it's plenty. And this concept is what we call the negative feedback inhibition. Negative feedback inhibition. So the alpha 2, which is found on the pre, causes negative feedback inhibition of further release of noradrenaline. So that one, the alpha 2 is found here. And when the norepinephrine goes back to itself and binds to it, it will communicate to the presynaptic terminal that stop releasing more of the norepinephrine or more of the noradrenaline. Do you get it? Hello?
Hello, yes, please.
Are you sure? Paulina, are you here? Paulina, are you here? So Paulina is gone. That's fine.
Yes,
Okay.
madam.
So that is it. The alpha 1 is on
Madam,
the.
please, I'm here.
Okay. So the alpha 1 is the woman. It's on the receiving end. So it's at the postsynaptic. And when it receives it, that's when it binds to the alpha 1 to cause the vasoconstriction. The alpha 2 is on the man himself. That's the presynaptic terminal. And when it binds to it, it tells it to stop releasing it. So when it binds to it, it tells the man to stop doing what he's doing. Do you get it? So that's for the alpha. Then when you come to the beta receptors, we said it causes what? Relaxation of smooth muscle and excitation of the cardiac cells, right? So the beta receptors, that one, it's not two things, it's three. Beta 1, beta 2, beta 3. You see, it's very easy to learn. So alpha is alpha 1, alpha 2. Beta is beta 1, beta 2, beta 3. The beta 1 receptor, B1, beta 1 receptor is located on the heart. This is my heart. Oh, it's not looking fine. So the beta 1 receptor, you can find it on the heart. So beta 1 is on the heart. And when it binds to beta 1, it causes what? Cardiac stimulation. That's when it causes cardiac contraction. Do you get it? The main site is beta 1. And when it binds to the beta 1, it causes cardiac contraction. Some lesser sites that it can be found is the smooth muscle of the GI. And when it binds to it, it causes contraction of the GI. But when we talk about beta 1 in adrenergic, The main thing that you should remember is it causes cardiac contraction, meaning it can cause an increase in heart rate. There's an increase in heart rate. Then beta 2, the beta 2. When it binds to the beta 2, beta 2 is located on your bronchial smooth muscle. Bronchial means we are talking about what? The lungs. We also have some on your blood vessels. Then we have some on the uterine smooth muscle. So it's on the bronchial smooth muscle, that's your lungs. Your vascular, that's your blood vessel. And the uterine smooth muscle, that's the uterus. When it binds to it, it causes relaxation or expansion. So assuming this is your lungs, and my lungs is not looking good. Assuming this is your lung, okay, if beta 2, adrenaline binds to beta 2, it expands the lungs. It makes it bigger. Making it bigger means what? There's more room for what? Oxygen to fill up. So, asthmatics, who knows their drug? Asthmatic, what's the drug they take?
Salbutamol.
Very
Salbutamol
good.
or Ventolin.
Very good. The Ventolin is
Ventolin.
very good. So the salbutamol, so asthmatics, their lungs are constricted. They are very small. So when they breathe in, the oxygen cannot really work there. So when you take the salbutamol, which is a beta 2 agonist, salbutamol is beta 2 agonist. It expands their lungs. So as it expands their lungs, it means more what O2 or more oxygen can enter. So that's the role of salbutamol. So the salbutamol you are seeing, that's how it works. It opens the lungs through a process we call bronchodilation. Do you get it? Do you get it? Then the same beta 2, we can find it on the blood vessels. The blood vessels, your veins, your arteries. And when they bind to it, it causes expansion. So it increases the size. Do you get it? So when someone is having hypertension and you give them, you can see that there's a drop in pressure, but we don't use it therapeutically. It's being used therapeutically is for the asthma and the rest. Do you get it? Then on the uterine smooth muscle. So let's say a woman is constantly having miscarriages and all that. That's because the uterus is always contracting, or maybe there's a risk of threatened abortion. It's not yet time for the baby to come, like, but the baby wants to come out. We'll give the beta 2 agonist to expand the uterus. So it will expand it so that the baby will have more space to sleep in, so that it won't be forced to what? Move out. That's what the beta 2 agonists do. So they cause what? Relaxation of your bronchial smooth muscle, your vascular and uterine smooth muscle. And the beta 3 receptors are found on fat cells, and they have a role in causing lipolysis. It means breaking down fat. As simple as that. Please, is it clear up to here?
Yes, please.
Very good. Then we have the dopamine. Dopamine, we are not going to talk about it because it's not mainly involved in what we are coming to talk about. So these are the responses with alpha 1, alpha 2. So we said when you bind to alpha 1, there's what? Excitation, there's constriction or contraction. So on your blood vessels, whether it's the arteries or veins, so there's arterial or arteriolar or constriction. So when you bind to alpha 1, think of the blood vessels becoming smaller. And when they become smaller, BP will increase. So there's arterial or venous constriction. There's uterine contraction as well. So it means alpha 1 can be found on your uterus, which will cause your uterus to contract, to become smaller. And if it is so, it means it can lead to miscarriages and abortions. So alpha 1 does the opposite of what? Beta 2. Then there could be pupil dilation. That's as a result of contraction of the smooth muscle. So in this, we call it mydriasis. Mydriasis. Okay. Then anything contraction, okay, so contraction of the ureter, contraction of the spleen, okay, and the contraction of the pilomotor muscles, okay. Then alpha 2 is what I said is on the man. When it binds to it, it makes it stop the release of noradrenaline. So alpha 2 will cause inhibition of noradrenaline, and that inhibition is negative feedback inhibition. So the same thing that is producing it, when it binds to it, it causes it to what? Shut down or stop releasing it. And also it has a role in insulin secretion. What is insulin? Insulin. Who has heard of insulin?
It's a hormone.
It's a hormone for so I know you know, but you don't want to tell me. So it's a hormone for what? Glucose regulation. It's what causes glucose to be pushed into our cells. So if people with insulin deficiency are what? They're diabetics. So alpha 2, we are saying it causes a decrease in insulin secretion. It means this will not be good for people with diabetics because it will cause a decrease in it. And it has these other roles as well. Then beta 1, I said beta 1 is mainly found on your heart muscles. And when you stimulate it, there's an increase in heart rate. The heart starts to contract. So there's an increase in chronotropic effect, that's heart rate. Inotropic effect, that's the pumping, the contraction itself. And dromotropic effect, that's the impulse generation. Okay, the beta 1, that's when it stimulates the heart. Chronotropy, heart rate will increase. Inotropy, contraction will increase. And then dromotropy, the impulses, the electrical signals will also increase. They all work together. At the same time, another site that you can find the beta 1 is your kidneys. And that one will cause secretion of renin. And when renin is released, a lot of processes will come in for it to increase BP. So that's what renin does. It can increase BP. Then beta 2 is purely relaxation or dilation. So it can cause vascular relaxation or dilation. So arteriolar dilation, intestinal relaxation, bronchiolar dilation. That's what you guys said about the salbutamol, right? Uterine relaxation. So beta 2 is relaxation, relaxation, relaxation. Then when you come down to it, can also cause stimulation of insulin release. It means beta 2 will be good for diabetics, but we don't use it generally for that. And then beta 3 will stimulate lipolysis, breakdown of fat. And in a way it would have a role in what? Thermoregulation, that's temperature regulation, because you know what insulates or keep us warm is what? The fat, right? So its therapeutic uses. So if you are saying that alpha 1 causes smooth muscle contraction, it means we can use it therapeutically when we want that, right? We are saying that alpha 2 causes inhibition of what? Neurotransmitter release. It means if we want to stop neurotransmitter release, we can use an agonist for it. If you are saying beta 1 causes cardiac stimulation, it means someone who is going into cardiogenic shock or the heart is not beating well, we can use the beta 1 so that the heart will beat. If we say beta 2 is for vascular smooth muscle relaxation, it means someone whose smooth muscles are constricted or contracted, we can use the beta 2 to expand it, right? So mostly the bronchiola, the salbutamol is used in that. Okay. So now let's talk about, you've heard of agonist and what? Antagonist, right? So agonist will stimulate the effect, antagonist will block it. So we have sympathomimetics. They are agonists. They can act directly on the receptors or indirectly via other pathways to enhance the effect of these noradrenaline and the rest. So you look here, we have what? Adrenergic agonist. And direct, you can have direct acting. Direct means they bind directly to the receptor. Please write these things down. Direct means they bind directly to the receptor. Indirect means they don't bind to the receptor, but they have other pathways of increasing noradrenaline and the rest. And mixed acting means they can do both binding to receptors and both indirect acting. So when we come to direct binding, we have selective and non-selective. Selective means that, as for me, I prefer only this type. So we have drugs that selectively binds to alpha 1, those that selectively bind to alpha 2, those that selectively bind to beta 1, those that selectively bind to beta 2. And non-selective are the ashawo ones. They don't like sticking to one person, so they can bind to different ones. Do you get it? So the non-selective alpha, it means they can bind to both alpha 1, alpha 2. Non-selective beta bind to both beta 1, beta 2. And we have them non-selective mixed. They bind to alpha 1, alpha 2, beta 1, beta 2. So they know they're everybody they like. Do you get it? Everybody. And then the mixed acting, they use both pathways. And then indirect, they don't bind to receptors and they act. So you get it, right? So selective means it's one person, monogamy. That one, they are loyal to their men, they are loyal to their women. Non-selective are the cheaters. And then when we talk about the extra non-selective, they are more like ashawo drugs. They bind to literally everything. Okay. So when you look at the selective, you have alpha 1 selective, phenylephrine. Phenylephrine, you mostly find it in a cold catarrh drugs. Cold catarrh drugs. So when someone has cold, who has cold right now? When someone has cold, there's excessive vasodilation. It means your blood vessels are dilated, have become bigger. So because of that, more of the mucus is secreted into the vessel. So that's why you secrete a lot of what mucus, your nose becomes runny and all that, because the blood vessels are dilated. So if you want to treat it, we need something to what constrict the blood vessels. Then we know alpha 1, when you stimulate it, it has excitatory effects, it causes vasoconstriction. So we'll use phenylephrine to bind to alpha 1. It will bind to it as an agonist to cause vasoconstriction. Then alpha 2, clonidine. It's used, but now we don't use it again because it causes depression. But another agent is methyl-dopa. You see that its use is predominant in what pregnant women. Methyl-dopa, and it's used for hypertension in pregnant women. Then beta 1, we said when we stimulate, it causes what increase in heart rates, increase in heart contraction. So the agent is dobutamine. So when someone's heart is not beating well, we can give dobutamine to increase the beating. Then beta 2, tebutalin. Tebutalin 2 is like salbutamol. It binds to the beta 2 to cause relaxation. If it's the lungs, it will cause the lungs to relax so that more oxygen will come in. If it's the uterus, it will cause it to relax. Then non-selective, they can bind to alpha 1, alpha 2, xylometazoline. Those that can bind to beta 1, beta 2, isoproterenol is the same as isoprenaline. Those that can bind to both alpha 1, alpha 2, beta 1, beta 2, epinephrine. And those that can bind to alpha 1, beta 1, and alpha 2, norepinephrine. Ephedrine can bind to receptors directly or use indirect pathways. Then the indirect acting, they don't bind to receptors. So we have releasing agents. It means agent that can cause the release of more noradrenaline. So amphetamine, tyramine, uptake inhibitor, those that will prevent the noradrenaline from going back into the presynaptic terminal. Cocaine, so it will cause the noradrenaline to be plenty in your system. Monoamine oxidase inhibitors, this is not it is rather MAO. They made a mistake. MAO. They will inhibit the enzyme that will break down the noradrenaline. So adrenaline will be plenty. Then the COMT inhibitors to prevent COMT. That's an enzyme that will break down the adrenaline. Okay. So when we come here, it's just talking about the affinity for them. So it's the same concept. You get it. Epinephrine will bind to epinephrine or adrenaline. They were in the middle. They don't have a type, so they bind to all. No, epinephrine prefers mostly the alpha. So you see alpha 1, alpha 2, and maybe to some extent the beta. The selective one, just alpha 1. For them, they said Yes, I want just this type. It's, William, are you there? Mary, are you there?
Yes, please.
Yes, please, madam.
Okay. Let me see. Ellen, are you there? Blessing.
Madam, please, I'm here.
Blessing, are you there?
Madam, please, I'm here.
Okay. Gloria Kwashi. Okay. Justina. John.
Madam, please, I'm here.
John Tilako. Tilako.
Yes, madam.
Okay, John is here. Nicholas Lante.
Madam,
Nicholas.
please, I'm here. Gloria question.
Gloria, you are now coming to your phone after your friend texted you.
No, ma.
Yeah,
I
you.
wasn't able to unmute myself. That's why.
No problem. Nicholas. My Ramatu, are you here?
Yes, madam. Please, I'm
Okay.
here.
Yeah, hello, madam.
Nicholas, they just texted you. Catherine Obin. Catherine Obin.
Yes, madam.
Who answered? Is it Benedicta or Sandicius?
Please, it's Catherine.
Catherine, you are talking. Yaya, are you here?
Yes, please.
Okay. At least you are listening. Very good. Okay, so let's continue. So that's what I mentioned. So now let's look at its effect. So alpha agonist, the alpha vasoconstriction. We say when you bind to alpha 1, there's vasoconstriction. So what are the application? It's used in nasal decongestion. I've explained this. So people with runny nose and all that is because there's too much vasodilation. So too much fluid can seep into your vascular system or your arteries, what have you. So if you want to prevent it, we have to cause vasoconstriction to block the holes that were opened by vasodilation. And also we can use it for systemic vasoconstriction. So people with low BPs or too much dilation of the blood vessels, we can use alpha agonists to constrict it. Do you get it? Then to retard absorption of local anesthetics. This is to say that when you give your local anesthetics like lidocaine, do you know anesthetics?
Yes, please.
Very good. When you give it like lidocaine and the rest, we can give this noradrenaline to constrict the area so that the local anesthetic can stay there longer. If it's not constricted and the thing is dilated, blood flow will just move it to other sites. So we'll give the local anesthetics to constrict it. And also it's used for ophthalmic vasoconstriction. Since we know it causes constriction of your the eye muscles and all that, it will later in turn cause the pupils to expand. So for the optometrists and the rest, to enhance viewing, you see that they will put some drops of this alpha adrenergic agonist on it. Do you get it? So the alpha agonist, what are some examples? So phenylephrine, xylometazoline, oxymetazoline. All these ones here are alpha 1. Then clonidine, apraclonidine, metaldopa. So currently what we use in hospital is the metaldopa. The dexmedetomidine is a new drug that's now, if you visit the ICU, you see that its use is also increasing. But the current drugs we are using most often for hypertension in pregnancy is metaldopa, and these all are alpha 2 agonists. Then the beta agonist, we say when you stimulate beta 1, it causes what? Cardiac stimulation, increase in heart rate. So its application means that we use it for people with inadequate cardiac output, those that their heart cannot beat well. So cardiac output is not really achieved. We use it. Then for bronchial smooth muscle relaxation, the B2. So those that have bronchospasms, whether COPD or asthma especially, we give them, or those in allergic situations where their lungs constrict too much. And also we use it for uterine relaxation, still the beta 2. So those with premature labor, the baby is not yet time, but the baby wants to come. We use the beta 2 to expand the uterus so that the baby has enough room to stay and will not wish to come out to this world. Then, okay, so the beta 2 agonist on the heart. So if we want to increase heart rate and the rest, we give the dopamine. That's a selective beta 1 agonist. Then are all beta 2: terbutaline, salmeterol, albuterol, formoterol. You guys have heard seretide, symbicort, right?
No, madam.
Oh, okay, no problem. So seretide, symbicort are all also asthmatic inhalers. Symbicort contains formoterol and then a steroid called budesonide. So formoterol is here and also helps in what expanding your lungs. Seretide contains salmeterol. Salmeterol is here, and our popular friend salbutamol is our Ventolin inhaler. That one you've heard of it. Then another agent, ritodrine. Ritodrine is mainly for uterine expansion, so for the premature labor and the rest. But funny enough, when you guys do your obs and gynae rotation, you realize that sometimes they use not the salmeterol, salbutamol for also premature labor. Okay, it will expand the uterus so that the baby can stay in and relax. Okay, so aside the butamine, the rest are all beta 2 agonists. Okay, then the indirect acting, the indirect and mixed acting. So this one, the example was what ephedrine, right? So that one will have almost all the functions over here. So we have the indirect acting. Ephedrine is mixed acting. It can bind to receptors directly or indirectly act. Then the rest are amphetamines, like how learning takes place is constant with reminders and all that. So as we move on, you realize that I'll keep on saying the same thing, and Paulina's mind will also turn back to it sad. And at the end of the lecture, Paulina will understand it, right? At the end of the lecture, someone will give me a very nice summary. It's not from the names I've been mentioning. So Beyonce, you are safe. So epinephrine. It's a very potent vasoconstrictor and a cardiac stimulant. If you remember, epinephrine is the same as adrenaline. And when we talk about alpha 1, alpha 2, it was always in the middle. That one, it didn't really have a type. It says me, I like everybody. So at low concentrations, it has beta 1, beta 2 effects. Whilst when you give it at high concentration, it has alpha 1 effects. Do you get it? So if it has beta alpha 1 effect, it means it can increase systolic BP via its what actions on the heart and then on the alpha effects. It can increase BP. BP is equal to what? Cardiac output times systemic vascular resistance. Have you heard of that formula? Have you heard of that formula?
Yes,
Yes.
Yes,
madam.
Very good. So BP is equal to cardiac output times TPR, or total peripheral resistance. It's also the same as the systemic vascular resistance. So we are saying epinephrine can increase this because it will bind to beta 1 to increase the cardiac output by increasing heart rate. At the same time, bind to alpha 1 by increasing the total peripheral resistance or systemic vascular resistance. The systemic vascular resistance increases when your blood vessel constricts. So when it constricts too small, it means the pressure in it will increase. It's like when a tap is flowing, the bigger pipes have low pressure, sorry, and the smaller pipes has a high pressure. So when you open it in a small lumen, you see that the water will gush out to move very fast. But when it's in a big pipe, it moves slowly. So when the blood vessels constrict via alpha 1, it causes what? An increase in BP because there's an increase in the resistance. At the same time, the adrenaline by binding to beta 1 will cause increase in heart rate. Okay. It can also bind to beta 2 in the blood vessels and all that. So its beta 2 effect is not mostly seen, but when it binds to beta 2, it can cause bronchodilation, some slight bronchodilation, at the same time, some slight vascular dilation. Okay. Clonidine is alpha 2. So when I'm talking about clonidine here, I'm talking about clonidine and the most common one that I said we use, that's the metaldopa, right? It lowers BP and decrease heart rate by what's causing the negative feedback inhibition, because when it binds to alpha 2, it will stop the further release of what's noradrenaline. So this is how you put it. Causes negative feedback inhibition of further release of what? Noradrenaline. So it means adrenaline in the system will be low. And if adrenaline is low, it means your BP will not increase. It means your BP will decrease. Heart rate will also decrease. So people with hypertension can take it. But the side effect is if heart rate is decreasing, it means if it decreases too much, there will be low heart rate, what we call bradycardia. That's one of the main side effects. Okay. So the one that is in use now is metaldopa. We also use apraclonidine, brimonidine, but that one is for glaucoma. It's in eyes. So you see, some people have eye drops that contains brimonidine and apraclonidine. That one in glaucoma, there's a different mechanism of action where we want to prevent too much secretion, the aqueous humor. So that one is different. So you see apraclonidine, brimonidine in your eye preparations. So now when you go to the pharmacy, be observant. Yeah, watch around. I'm at Asian Pharmacy, the school bus road. So you can come around if you are willing. Then I'll show you some of these drugs around. So metaldopa is alpha 2, which I've mentioned, and it's mainly used for hypertension in pregnancy. Dobutamine is beta 1. So it's selective beta 1. It means when it binds to it, it increases what? Your heart rate, increases the contraction. So it's used for short-term treatment. We don't put someone on dobutamine for long, just short-term to increase the heart rate. So often people with heart failure where it's decompensated, the heart is not pumping at all. We often give them the dobutamine short-term to increase what? The heart rate. Tebutalin is beta 2. So tebutalin is like salbutamol, salmeterol, formoterol. For them, the increase was smooth muscle relaxation. Its main use is for bronchospasms. So the major use here is the bronchospasm, and minor use is for premature labor. So salbutamol fall into this category. You see how the names are very easy to learn. Salbutamol, albuterol, bilateral, formoterol. This is also another one, formoterol, salmeterol. You see, very easy to learn. Then ephedrine is the mixed acting one. So that one can do what? Both actions, right? Then the other sympathomimetic, other applications. So as a mydriatic will increase the pupil size. So it's used those who have eye conditions. You see that sometimes when you visit, they will put some drops in your eye. That's just to expand the pupils to cause mydriasis so that the optometrist can view your eye. And also for glaucoma, I've mentioned it. We have apraclonidine and brimonidine to increase intraocular pressure. So knowing all this, it means that when someone has hypertension, we can block alpha 1 with its antagonist so that there will be vasodilation. When someone has increase in heart rate, tachycardia, we can block what? Beta 1 so that there will be a decrease in what? Heart rate. So this is where other drugs, the major drugs that we have, antihypertensives and all that will come in. So we are coming to just look at a few of them, then we'll talk about it. So since we have alpha adrenoceptor, beta adrenoceptor, it means we would have what? Alpha adrenoceptor blockers and beta adrenoceptor blockers. And some can be selective and some can be non-selective. You get it? So the alpha adrenoceptor blocker. So the non-selective, this is alpha. This is alpha. The non-selective one, they bind to both alpha 1, alpha 2. The major drugs are phenoxybenzamine and phentolamine. Phenoxybenzamine and phentolamine. It's used in a condition called pheochromocytoma. Beyonce, spell pheochromocytoma. Beyonce.
Yes, madam.
Spell pheochromocytoma.
Yes, madam. Please, I should.
Spell it. You heard it. It doesn't start with F. It starts with P for your information.
Please, I should spell.
Pheochromocytoma.
Hello.
It's fine. Beyonce, you can mute yourself. Please mute the microphone. Okay. So the non-selective, they block both alpha 1 and what? Alpha 2. Do you get it? They block both alpha 1 and alpha 2. Then the alpha selective, they block alpha 1. So by blocking alpha 1, it means they are inhibiting vasoconstriction. They are preventing vasoconstriction, meaning there will be what? Vasodilation. And for these ones, these are their names: prazosin, terazosin, doxazosin, alfuzosin, tamsulosin, indoramine, urapedol. They are exceptions. So what do you notice? The trend is what? They all end in zosin, zosin, or osin, osin. Very easy to understand. So prazosin, terazosin, doxazosin, alfunosin, indoramine. So normally these things, you also have to know the exceptions. Indoramine, urapedol. You get it? But the common one that we use is which one? Who can tell me the most common one? I know Paulina's name because she answered the question for me. Who can tell me the most common alpha selective agent that we use? Anyone to say it? So the most common one is tamsulosin, and it's used for people with BPH, benign prostatic hyperplasia. So it's used mostly in the men. So these are the alpha 1 selective. They cause what? Vasodilation. Okay, they cause vasodilation. And then the alpha 2 selective, the only example we have is yohimbine. Yohimbine. That one cry was seen to have some sexual enhancing effect in rats. That's why men, they like it when these things causes sexual enhancement. So the scientists, who are mostly men, they tend to work on it a lot. So that's the only alpha 2 selective inhibitor that we have. Then when we talk about the beta receptor antagonists, they're also very nice to learn. So the non-selective, or the first generation, we have nadolol, pentobutal, pindolol, propranolol, timolol. The common ones among these are propranolol, timolol, and pindolol. Okay. Then the beta 1 selective, atenolol. Atenolol is so common. It's all for those with hypertension. Bisoprolol, esmolol, metoprolol. Anything that you can take off, add olol, and it becomes a drug. Then third generation, cartilol, carvedilol, pusindolol, labetalol, you realize that for carvedilol and labetalol, there's some asterisk on it. That is because for them, in as much as they can block beta receptors, they can also go to the alpha receptors and block it. So their use is very, very good in certain situations where there's heart problem at the same time increased BP. Then the third generation, celiprolol, nebivolol, betaxazole. So the beta blockers end in what? Olol. Alpha 1 blockers end in osen. You get it? So alpha adrenergic antagonists. So those that are mixed, that are non-selective, phenoxybenzamine, phentolamine, alpha 1, prazosin, terazosin, tamsulosin, then alpha 2 is yohimbine. Beta adrenergic antagonists. The mixed acting or non-selective is propranolol, timolol, pindolol. Beta 1 selective is metoprolol, atenolol. Then those that have alpha 1 and beta effects, labetalol and carvedilol. So add carvedilol to this. So the same thing that they've classified here, non-selective, phenoxybenzamine, phentolamine. So that's why I said, as we move on, you realize that most of these are repetitions and it will help you enhance your learning. Alpha 1 selective, the osins, prazosin, terazosin. Alpha 2, yohimbine, edoxazan. Edoxazan is not used in Ghana here. Then we have ergot derivatives. They are mostly classified because it's seen that they have what? Alpha adrenoceptor blockade. Do you get it? The ergotamine, dihydroergotamine. You see that once in a while you come across it in the hospital. Okay. So clinical uses of the alpha adrenoceptor is used for hypertension. So since alpha 1 causes increase in BP, if we block it, it will cause what? A decrease in BP. Do you get it? Then pheochromocytoma, Beyonce, this is the spelling. So this is, it's not just Beyonce, I'm sure all of you, but because I placed it on the spot. So this is phenoxybenzamine. Pheochromocytoma is a tumor of the adrenal gland. And when it occurs, a tumor is like, it becomes what can, it's, I won't say cancerous, but there's rapid multiplication in the cells. When there's a tumor of the adrenal gland, the adrenal medulla, the cell that produces noradrenaline, it means the cell that produces adrenaline, it means adrenaline will be plenty in your system because there's tumor of the cell that will produce it. So it will be plenty. So in this case, we use phenoxybenzamine. This one, you come across it in the hospital, especially, I don't know, those who will be doing rotations outside. I have been to Confanoche for a while, so I know how these cases come about. You see cases of pheochromocytoma. Then I told you the common one that we use is also tamsulosin in BPH, benign prostatic hyperplasia. People, you see, they often have urination problem. They are urinating frequently. When they go cry, it's not coming. So we give them tamsulosin to reduce all these symptoms. Then
Madam,
alpha, yeah,
madam,
yeah,
please, what did you say about the pheochromocytoma? We didn't hear.
the pheochromocytoma. So I mentioned that.
Yes,
Can you mute the microphone? It's a tumor of the
please, I can
adrenal.
hear.
Okay. Can you mute it? It's a tumor of the adrenal medulla, and we explained earlier that the adrenal medulla helps in production of what? No, adrenaline. So if there's a tumor is what? Rapid replication of cells. So if there's a tumor of the adrenal medulla, the place where no adrenaline is released, it means there will be too much production of this adrenaline because there's too many cells producing too many adrenaline or too much adrenaline. So in this case, the patient is exposed to what? High levels of adrenaline. High levels of adrenaline means the adrenaline will go and bind to all these receptors and cause the deleterious effect. There will be excessive vasoconstriction, excessive what? Increase in heart rate and all that. So in this one, the major thing we are targeting is the alpha 1 effect, the alpha effect. So the drug that we use mostly is phenoxybenzamine, and to some extent labetalol because we want some beta effects. Okay, So that's all about the pheochromocytoma. And what I added was that I have been at Confanoche, and I've seen that this case is not something that you say is rare. Some people get it a lot. So when you go, you see the use of these agents over there. Then the BPH, that one we use tamsulosin because there's vasoconstriction. We will prefer tamsulosin to enhance relaxation. And tamsulosin is more specific to even that site. The tamsulosin does not really bind to the blood vessels. It goes directly to the urinary tract. It goes directly to the male sex organ to target this region because it's alpha 1A. So in all two, we have subtypes. Okay. Then alpha 2, they are the autoreceptors. So the alpha 2 receptors, they act by blocking, causing what negative feedback inhibition of these noradrenaline and the rest. So if we use them, it will increase the release of norepinephrine because the normal alpha 2, when you bind to it, when methyl dopa binds to it, it decreases the release of noradrenaline. So when you block it, it means it's going to increase the release of noradrenaline. Seeing the use of yohimbine for therapeutic purposes, but we have it being sold at the pharmacy and the rest. So once in a while, patients with maybe shock, or patients whose BP are crashing and you want to maintain them or stabilize them, once in a while they use these agents. So as I said, neohimbine was also seen to be an aphrodisiac. It improves sexual function in male rats, but evidence in humans is limited. So if you use it for sexual enhancement, it's at your own risk, but because we've not tested any evidence in humans. Then we come to the beta blocking agent. So I first began by saying that pharmacology is easy in such a sense that if you know what the body is doing, you know what the drug will also do. So we know that normal beta 1 activation causes what? An increase in cardiac stimulation. So there's increase in heart rate, increase in heart contraction. It means when we block it by using a beta blocker, there will be what? A decrease in these effects. We know that a normal beta 2, when you stimulate it, there will be what? Relaxation of your bronchial smooth muscle and uterine. So the patient can breathe well. It means that when you block it, the patient there will be what? Bronchoconstriction. So beta 2, one main contraindication, one main people that we don't use beta 2 in will be which people?
Asthmatic patient.
Very good. Who said that? Angela. Very good. Asthmatic people. Because if you use a beta blocker in an asthmatic patient, it will cause what? Vasoconstriction, bronchoconstriction. Already, this patient cannot breathe well, and you are blocking the breathing pathway. So, what will happen? The patient will tip into an attack. So, pharmacological action. So, the blockers will decrease heart rate, contractility, and the rest. So, we use it in arrhythmia and people with angina to act as an antagonist over there. The BP is not really much affected, so we don't really use it for BP use or whatever. But it's to some extent those with the mixed acting, they have a role in BP regulation. And we know that if it decreases cardiac output, BP will decrease because the formula is what? BP is equal to cardiac output times TPR. So by decreasing cardiac output, they are directly proportional. Are marked in JHS3. You should understand. So if you decrease it, BP will equally decrease. Then intraocular pressure. So these ones can also be used in glaucoma. So when you go to your pharmacy, you see Timolol eye drop over there. I don't know if anybody have been using these agents. This is how it works. It's also helping decreasing the aqueous humor production, and this will help decrease your intraocular pressure. In glaucoma, the eye pressure is increased, so we want to decrease it, and that's what we use. Then for bronchial smooth muscle, it increases airway resistance. It causes what? Bronchoconstriction. So that's why Angela said for asthmatics, you cannot use these agents. Then glycogenolysis is also blocked. So it can increase the likelihood of what? Hypoglycemia. Because if you are blocking what is glycogen? It's the stored form of glucose, and it's released when your glucose levels go down. So if you give a beta blocker and you block it, I mean the patient is constantly going to tip into what? Hypoglycemia. This is the end of it. I want to ask, did you understand it? That's the first question. Did you understand it?
Madam,
Hello, Melissa. Let me do a roll call.
doctor.
Uh, Jessica Dede. Miraculous Sir.
I'm present, please. I'm present.
That's the Miraculous Sir.
Yes, please.
Okay. Name not available. Who is that?
Madam, please, this is Cynthia. My name is not Elise. I'm with Beyonce and Vera and Mary.
Okay. I've screen recorded, so this will be the attendance. Okay. Renetta Opoku.
Madam, please, I'm with
Okay, Renetta.
Madam.
Uh,
Madam.
please, can you mute your microphones? Angela. Angela
Madam,
Kumu. Yeah.
Madam, please, we are pairing.
You people.
Angela,
Yo, you're lying.
Madam, please, it's true. Hey, Madam. Hey, Madam.
Ayo,
Madam,
Martin.
I can't say, in the message box, I wrote that we are pairing.
Ayo, Martin. Paulina Boache. Okay, Paulina will be here.
Yes, madam.
Madam,
Yeah.
so we are writing our names in the message box.
I won't look at it. I won't look at it. Grace Wampong.
Madam,
Yes, madam.
Is that Grace? Okay.
Yes, madam.
Gloria Kwashi. Ernest.
Yes, madam.
I'm starting with Emily.
Okay. Okay, so you guys are pairing, eh? Betty. Betty Yelson. Okay.
Yes,
Let's see.
madam. Madam, please.
Did you guys understand what we just did? Hello? Angela, mute your microphone. Angela. Yeah, okay. Did you guys is it clear? Any question? Any question? You can unmute and talk if you have a question. Did you even write notes?
Yes, madam.
Madam.
Yeah.
Madam, I
So
have
Melissa, are you there?
Yes, please.
Okay. Tomorrow, how's your schedule like?
Yes, so please, we have two classes. Two quizzes tomorrow.
Mm-hmm.
And yeah, and we will, and it's a combined class. So there are some periods and the nursing students will have class, and there are some periods the mental students will have class. So the only time we can actually have the class will be very early in the morning, 6:30 a.m. or around 5:30 p.m. in the evening.
6:30. Yeah, no. Uh, there will be no 30 minutes available during the day.
During the day. No.
When is your second quiz?